for this important webinar on NABH. We all know NABH is no longer an ornament, but a necessary tool for each hospital and individual practitioner as well. So to take us forward, we have very eminent speakers, and especially we welcome Dr. Samina Zamindar, who is one of the most well-known figure in this field. And we also have Dr. Anjun Mukherjee, who is an NABH assessor, as guest speaker in this meeting, beside our OSWB members. So before I request Dr. Sudipta Mitra and Dr. Saurabh Sannal, our moderator, to take forward the meeting, I would request if Dr. Kajal Ghosh has joined. He was still in the clinic. He said still 70 patients to see. So if I don't think Dr. Kajal Prasad Ghosh is here, so may I request Dr. Rutish Chandra Pal, our chairman, sir, to say a few words before I hand over the meeting to Dr. Sannal and Dr. Mitra, please. Dr. Rutish Chandra Pal.
I am here. Good evening. Most welcome all of you. Let's show up to start with.
Okay, Saurabh and Sudipta, please carry the meeting forward. I'll request all the speakers to be on time, and so that we have effective discussion. There are quite a few questions already being forwarded to the moderators. If time permits, we'll take them because there will be other questions as well. We'll try to do justice to this webinar. Thank you so much. And over to Sudipta, please, and Saurabh, please.
Thank you, Shugato. And welcome everyone to this evening of for NABH Accreditation, Raising the Bar, Journey Towards Quality. As Dr. Shugato Pal has introduced, chairperson for the evening will be Dr. Rutish Chandra Pal. I do not think it's necessary to introduce him anymore. Kindly mute yourself, Dr. Arup Ghosh, sir.
Oh, sorry.
Let me introduce you first. So Dr. Rutish Chandra Pal is very well known to us. He heads the Shistru Group of Hospitals in West Bengal. As the panelists of the evening, we'll have Dr. D.B. Sharkar, sir, Dr. Arup Ghosh, sir, Dr. Sushanta Mukherjee, sir, Dr. Ashik Chakraborty, sir, and Dr. An Mohanto. And we have very eminent speakers in the evening today. Dr. Saurabh Sannal, sir, who is also my co-moderator, who will be speaking on NABH, why necessary. And the other speakers I will be introducing as we go on in the evening. So not wasting much time, and welcoming our guest speakers, Dr. Samina Zamindar, ma'am, most welcome, and Dr. Anjun Mukherjee, sir, who's again a guest speaker of today's evening, and all the members who are here. Let us start with the first speaker of the evening, Dr. Saurabh Sannal, who's going to speak on NABH, why necessary. Sir actually has his two centers, one in Sirampur and one in Dankuni, and he has got his center pre-accredited with the NABH. So over to you, Dr. Saurabh Sannal.
Saurabh, Dr. Kajal Ghosh has joined. If we have 1 minute,
Of course.
Welcome everyone. He's the president of OSWB.
Yes.
Dr. Kajal Ghosh, please, before we start. Dr. Ghosh, I can see his name now. We can then go ahead.
Should I share my screen?
Yes, I can see Dr. Ghosh's name here. Yes, go ahead, Saurabh. Sorry. Oh, Kajalda is here. Kajalda. Dr. Kajal Prasad Ghosh.
I think he has not joined.
I think he's
Call. Hello.
Yes, sir, we can hear you.
Yeah.
Please go on. Yes, sir.
Yes.
We can hear you.
Sir.
Please go on.
Thank you. Thank you, Sudipta. Friends, welcome to this webinar. Journey towards quality. Well, this term and this year on means that what we want to do. Well, it is basically a webinar to make the ophthalmologists practicing in different parts to impress the importance of NABH and because in the initial inconvenience, actually because initially inconvenience, we usually opt for saying it's not that necessary. It is absolutely necessary. So I request all present over here to hear this seminar very thoroughly, and let us all try to raise our quality and go ahead by the standards of NABH. This is in small my saying, and I request Sudipta to take over the. Yeah. Okay.
Thank you, sir. Thank you very much, sir. Saurabh, you can go on.
Yeah. So thank you. Thank you, OSWB, for organizing a very important seminar on NABH accreditation. And I will just take few minutes because today I am a moderator also. So I will not take much time. I have only 21 slides. I will explain three things. What is accreditation? Few words about NABH and benefits of getting accredited. I will not discuss many things about NABH process of accreditation because other speakers are there. So let me start with the thing that quality. Quality means doing it right when no one is watching. It is said by Henry Ford. Why I am telling this? Many areas in healthcare are managed by our staffs, often unsupervised. So this is the area we need to focus on, this quality issue. So hospital accreditation is basically means a public recognition of the achievement of the accreditation standard by a healthcare organization demonstrated through an independent external peer assessment of that organization's level of performance in relation to standard. An International Society for Quality in Healthcare defines accreditation as a self-assessment. Remember the word self-assessment and external peer assessment, both process used by healthcare organizations to accurately assess their level of performance in relation to established standard and to implement ways to continuously improve the healthcare system. So accreditation initially was voluntary. It was a private process, swiftly evolving towards public regulation. Maybe in near future, it becomes compulsory or mandatory for all healthcare organizations. Healthcare system needs uniform standard. Why it needs a uniform standard? It's a huge advancement in technology in healthcare and large variations in delivery standard. Each hospital has its own ways of delivering the standards. So there it adds to risk, which is already there in practice of medicine. And there are increasing possibilities of error with this advancement of technologies if we do not have any standardization. So that comes to dissatisfaction, confrontation, legalities, and loss of reputation of the healthcare organization. So all these things needs to be standardized before they are placed in service. So NABH standardizing healthcare. NABH is National Accreditation Board for Hospital, is a constituent board of Quality Council of India, that is QCI, set up to establish and operate accreditation program for healthcare organization. In the certificate itself, you see it is a constituent board of Quality Council of India. NABH has been established with the objective of enhancing health system and promoting continuous quality improvement. International Society of Quality in Healthcare, that is ISQA, has accredited the standards for hospital developed by NABH India. This is important. that internationally, NABH is also accredited its standards under its international accreditation program. The approval of ISPOA authenticates that NABH standards are in accordance with the global benchmark set by ISPOA. The hospital accredited by NABH have international recognition. So NABH eye care standard, NABH for hospitals and NABH for eye care organization. These are got two different issues. HCO, there is a healthcare organization, or SHCO, small healthcare organization. Standards proposed by NABH is for multi-specialty hospitals. And many of these proposals are not applicable for eye care organizations. EIOS and NABH accepted and proposed separate eye care standards for accreditation. Separate NABH ECO standards are published exclusively for standalone eye care organizations. So basically, what accreditation means, it is a statement to our patients and society that we care for you, we are accountable, we comply with the law, we are dedicated to quality, and we are in. There is an inertia towards this issue of getting NABH accredited or improving the quality. We are perfectly doing our job, so why to go for accreditation? We are too busy with clinical works, no time to think about accreditation. It is not mandatory, so we will think about when it becomes mandatory. It is difficult to get accreditation for small setups. We need to change many things, including infrastructure, so it is not possible for us. We think of hiring some professional group, as Dr. Zamindar was mentioning, who will work for us and make us ready for accreditation. And it involves a lot of cost to get accreditation. All these common beliefs are not true. All the organizations in the country or in the world are always, they go for accreditation. Like universities get by NAC, healthcare by NABH, and many other organizations. So it is not impossible. It is possible to get accredited. First, believe in that it is possible to get accredited. So there are enough benefits of accreditation. The moment you get accredited, your hospital goes absolutely in harmony. Whenever you listen to a music, disharmony always creates cacophony, and NABH creates harmony in the organization, improves efficiency. It's always that efficiency and effectiveness. It is important for any organization. So low resource wastage and high goal attainment. These are two important whenever you get yourself accredited. Less chance of error. This is very, very important. Whenever you follow the protocol, the SOPs, the checklist, there are less chance of error. We all know this. There's a surgical safety checklist. Every time we do a surgery, we know that every time we have to follow that checklist. It can avoid many complications, both clinical and non-clinicals, altercation, verbal communications, everything should be very smooth, and NABH accredited hospital has got a set protocol for everything, starting from emergency to the service delivery. Better time management, always. It is whenever you have an SOP, what Dr. Zamindar will be discussing, and if you follow that thing, your time management is perfect in a hospital. Transparent system builds trust between the staffs, your colleagues, your patient, and everybody who are involved in this healthcare organization. It creates trust. And very important that whenever you get accredited, your staffs gets a very high self-esteem. They know better that what are their abilities and what they can deliver. So this is also very important in the staff training protocol, the continuous improving your checks and balances in the hospital. All these things helps the staff to have a better staff, and every day they deliver better. Satisfying patients. It always very satisfied. Patients are very satisfied. Starting for your cleanliness, your what exactly Dr. Samina was telling that they have shifted to a COVID protocol hospital. That's now in this era, these patients get satisfied whenever they see that everything is in proper shape. Of course, it increases reputation and revenue. So quality is never an accident. It is always the result of high intention, sincere effort, intelligent direction, and skillful execution. It represents the wise choice of many alternatives, as said the US Marine William F. Austin. So let us start the seminar proper, raising the bar, journey towards quality. And thank you for your patient hearing. I will request Sudipta to call on the next speaker. Thank you. Sudipta, please. So next speaker, I think is Dr.
Yeah.
Chanda.
Yeah.
Should I start sharing?
Yes, Shuchandadi, you can start sharing the topic. We know Dr. Shuchanda Shah as a renowned practitioner attached with Disha Hospitals. The topic on which she's going to talk today is steps to get NABH accreditation. Shuchandadi, go on.
Is my screen visible?
Yes.
Achha. So good evening, everybody, and thank you SWB, Shorabda, for giving me this opportunity to speak on this subject. Being a Sunday evening, I will get straight to the point so that we wind up on time. And just a bit. So NABH accreditation can be of two types, and full accreditation
We cannot hear you, Shuchandadi.
here is called ECO or Eye Care Organization. To make matters easier, the entry-level certification has been developed by NABH, which has more simplified objective elements, and it is the first step towards NABH accreditation. And to facilitate this process, a new platform has been launched by NABH in 2018 called HOPE, Healthcare Organizations Platform for Entry-Level Certification. And this is the platform that is currently in use for all healthcare organizations who want to apply for entry-level certification. And the recent version is been updated in April 2021. The complete certification process has three main parts: registration, documentation, and fee submission. HOPE is a platform that provides complete information about certification process. They give you guidebooks, presentations, documents, videos, and there is also an additional support of a toll-free helpline. So first we have said is registration, but before that, once we go to the NABH website, we find that this is the page that opens up. There is about us, accreditation, certification, empanelment, education and training, and NABH International Standards and Resources. So first, if we click on NABH Standards, then we reach this part where we find that there are 3 guideline books which is applicable for eye organizations. So anybody who wants to apply for full accreditation needs to consult these standards, needs to document and apply with these standards for ECO or eye care organization. And those who are going to apply for entry-level certification and is an HCO, that is a healthcare organization with more than 50 beds, would need these standards, and SHCO or small healthcare organizations with beds less than 50 beds. These books can be downloaded free or they can be bought at the costs that are written below. So first, once the healthcare organization feels that it is time to implement and improve and standardize their quality, and they are interested in NABH, they need to register online at hope.qcin.org. And once we open up this web page, we find that there is this option of login or register. So somebody who has registered earlier and is going back a second or a third time would log in with their password. But anybody who is registering for the first time would need to click on register, and this hospital user registration form will open up. Now, once the required data has been put in, the user receives a username and password in their registered mail ID. It is a temporary password which will be valid for 21 days, within which time the HCO or the SHCO needs to update all the documents that is necessary. And so this page opens up, web page opens up with this name of SPOC on the right-hand side, which is the single point of contact. The person who will be communicating with the NABH portal, his name has to be put in here. And then the home page here shows that registration form, how to apply, and list of documents. But one has to be very careful that whatever details have been are being entered can be edited, but once they are submitted, they cannot be edited any further. So there are these various sections that need to be filled up, out of which the first one is the general information, which in this general information, we need to fill up the contact details of the hospital, the person who will be coordinating, hospital registration number, date, type of ownership. Next would be statutory compliances. Statutory compliances involve acquired license, that is the CMOH license in West Bengal, which is called the CEA or Clinical Establishment Act license in other states, license for permission for generating BMW with the Pollution Control Board, NOC for fire. If one has a pharmacy, then one would need a license for retail, bulk, and narcotic drugs. If one has a spectacle shop, they would need to provide a trade license. And these would be the license depending upon the healthcare organization facilities that are being provided. And details of MOU of various outsourced services also needs to be uploaded, like the MOU with the ambulance services, a nearby laboratory, nearby multi-specialty hospital ICU, so that in case a patient is not doing well, the patient can be transferred out. BMW with collecting agents, MOU with collecting agencies. Now, if there are laundries and canteens, then all these MOUs also needs to be in place by that HCO or the health SHCO. The third is the hospital staffing and details pertaining to hospital staffing, like consultants, nurses, paramedical staff, administrative and support staff needs to be filled up in this page. And this is the third point, that is hospital staffing. The fourth is clinical services, where we need to upload data on OPD, IPD data, occupancy rates, scope of services, the details of which Dr. Samina will be talking about later. We also need to put in information regarding 10 most frequent clinical services where admissions are taking place, 10 most frequent diagnoses in our inpatients, 10 most frequent surgical procedures at our hospital, and choosing the type, what is the sterilization modes that the hospital is choosing. Regarding physical infrastructure, the bed strength, numbers, categories, the services offered. Here we also need to put in the location details of where the block room is, where the OT is, where the ward is, in which building, which floor, and that needs to be put in there. Regarding laboratories, what are the facilities that are given? Clinical like in Disha, we have clinical microbiology, serology, pathology. And so whatever services are being provided, other than that, there are sections where we need to put in our data regarding availability of electrical supplies, whether they are generators, UPSs, water supply, number of water tanks, whether corporation supply or also something is outsourced, elevators, types of trolleys, which also includes wheelchairs. And here we also need to do a geo-tagging with the help of GPS camera app through the mobile phone, so that the when the assessment is being done by the desktop assessment, they can find the location of these trolleys and wheelchairs by their GPS system. We also need to upload data on ambulance accessibility, uniform signage system in the facility, etc. Quality improvement includes details of committees, the minutes of the meetings, registration, billing, admission, SOPs, and evidences, patient and family education that includes uploading samples of consent forms and our signages regarding patient rights and educations, patient-related processes, nursing care process, which includes the bedhead tickets, 3 samples of bedhead tickets, filled up bedhead tickets, medical management, human resource training, what is the training protocols that are being followed, and staff records, infection control like autoclave indicator, photos, autoclaving details, microbiology culture reports, management procedures, how the incident managing is done. It's we need to put in evidences of some incidents where root cause analysis and a corrective action and preventive action or CAPA has been done, and safety drills, fire exit protocols, and records. So once our documents are ready, and they need to be uploaded very carefully section wise using both the web portal. First, the web portal is used, and then the mobile application wherever it is indicated. So this is just an example of certain documents, like this is a directional signage. This is employees' rights and responsibilities. Similarly, there are patient rights and responsibilities, mission, vision of the hospital. This is a pharmacy license. This is scope of services, where we not only need to put in what are the services that we provide, we also need to put in what are the services we do not provide, exclusion of services. So coming to the point, so once we have put in all our data, we need to save, but before we click the submit button, after filling up all necessary details and attaching all required documents, we must be doubly sure that there is no error, and then we finally click on the submit button. Now, those documents that require to be uploaded through the web portal will have this icon which says upload any file next to them as highlighted, and those that need to be uploaded through the mobile will have this icon which says video uploaded file. Now, these are the blue camera on this and this side in the mobile application. The mobile application happens through downloading the HOPE on-site app. We need to download the HOPE on-site app on the registered mobile number, and then these are the places where the blue camera shows that we have not yet uploaded the photographic evidence, and once it is uploaded, it changes into orange. After the documentation, fee needs to be submitted. At the entry level, it is fixed at depending on the number of beds, and HCO is one that has more than 50 beds. SHCO has up to 50, less than 50, or up to 50 sanctioned beds. And in ECO, the price varies depending on the number of surgeries that are performed, and the minimum is around 50,000. So once the data has been submitted, it goes in for desktop assessment, which is done online by the DA team. They can raise some non-compliances, that is, they can raise certain issues where they are not comfortable with the process that is being followed in a certain area, and they can raise their queries. The organization will get a specified timeline to answer satisfactorily to these non-compliances, either with the help of, with their evidences. And after that, the DA team verifies all the replies. After the non-compliances or the NCs have been closed, they are satisfied, the DA team is satisfied, on-site assessment is done by an assessor. After that has been done, there may be more NCs which would need to be closed, and a final quality check will be done by the assessor as well as the experts. And if everything goes fine, and we are aiming for ultimately what is our goal is the certification committee, digital certificate, which we are now getting digitally, which is finally approved by the certification committee. But unfortunately, if after 2 attempts to clear NCs has not been cleared, then the application gets rejected. But there is an appeal facility which can be done after paying the appeal fees. So some key points is save the information on desktop portal first, and then use the mobile application for further documentation uploads. But both the desktop and the mobile application cannot be used simultaneously. And active internet connection is very much necessary during the uploading. But please make sure that the details are filled accurately before you press the final submit button. Just a quick summarization: registration on web portal, a temporary number is generated, and then document submission, fee submission, we get a permanent number. And then step 2, desktop assessment begins with by the DA team. They can give NCs. If you do not get an NC, you directly get a date allotment for on-site assessment. If you do get a non-compliance or NC, a closure needs to be done. And then finally, a date is given for on-site assessment by assessor. Again, the NCs need to be clear. If you do get some NCs, if you do not get some NCs, or if after your NCs are cleared, then we finally get a certification granted, and which we get as a printable digital certification. But unfortunately, if they have not been able to clear, we can put in an appeal, or we need to apply over once more. Thank you. Thank you, Shudipta.
Thank you, Shuchandati. That was an excellent detailed presentation with a beautiful summarization. We'll come back to you with questions which all of us must be having, but we'll quickly go to the next speaker, and I'm extremely honored. If you can just stop sharing, Shuchandati, I'll stop this time.
Yeah, sorry.
Yeah. So I'm extremely honored today to introduce our, is my screen visible? Is my screen visible?
Yes.
Yes, visible.
So I am extremely honored today to introduce our guest speaker, Dr. Samina Zamindar. And ma'am has been a prolific cataract surgeon, is the Chief Medical Director of Zamindar Microsurgical Eye Center, Bangalore. But her achievements and awards have been in Young Quality Achiever at 4th International Conference of Consortium of Accredited Healthcare Organizations at Chennai on 8 April 2018. She has been the assessor with NABH. She has been the chief instructor in AIOS for implementation of NABH standards for consecutive 3 years. And she has started a platform, Eye for Quality, of which even I am a part, to teach, learn, and share ideas. So, and she has, her efforts have endeavors towards NABH accreditation, getting NABH accreditation for other doctors, and teaching about it, helping them out, has been a long process, and she's still into it. So welcome, ma'am, and she's going to talk on one of the very important points of NABH, SOP, why, how, and what, standard operating procedures. So welcome, ma'am, and over to you.
Thank you, Dr. Sudipta, so much, and thank you, West Bengal Ophthalmic Society, Dr. Sugato, Dr. Shaurabh, and all my friends here for letting me be a part of this webinar today. And Dr. Sudipta, please take the liberty to stop me because I will go on otherwise. I'm capable of doing that. So just stop me when I should, and I'll be grateful to you for that. I hope you'll allow me to share my screen now.
Yes, ma'am. Please do. Please share your screen.
Is that all clear? You're able to see my screen? Right. So today I would like to talk about a standard operating procedure for uniform patient care. For a change, let's not talk about NABH. Let's assume that none of our friends here who've joined us for the webinar uh, is thinking about getting an NABH accreditation. Let's think about what if we had to have standard operating procedures in our hospital with or without NABH, and then how it will impact us and what difference it will make in the way we practice. Is it really worth doing all the efforts? This is something which is very close to my heart because most of the times when I go as an assessor to assess an hospital, uh, most of the times I do get copy paste material for standard operating procedures. And I feel that when Dr. Paul asked me to speak something about NABH, I said I would like to talk about this. I believe completely in the magic of standard operating procedures. And I feel that by doing it correctly, implementing it correctly, and learning how to get your organization onto the path of SOP is the true way, the grassroots level way in which you can improve quality in your hospital. If you do everything else, but you do not have your own SOP written by the stakeholders at the grassroots level, it will be impossible for you to maintain the quality standards in future. So thank you for your time. And this pandemic, this COVID pandemic, is a humbling reminder that plans don't always work out as intended. Time spent planning is still time spent. Allocate more time for just doing. Plans can become irrelevant and the time is gone. Learning to live gracefully with uncertainty and coping with the unknown. So, this is some new learnings which the pandemic has taught us. And let's allocate more time for doing rather than planning. So, the COVID-19 pandemic changed everything. And there is a reason why I'm talking about this, why it has a relevance to standard operating procedures. We had to pull up our socks, just like Sir Thomas Carlyle said that our main business is not to see what lies dimly at a distance, but to do what lies clearly at hand. And we had to learn to live with the new facts. First, essential medical services cannot be postponed indefinitely. Second, business continuity is important for all of us. And third, we had to find safe ways of doing it. So our team achieved the WASH certification. This was last week. This is last year, last week. So sorry for that. Workplace Assessment for Safety and Hygiene is a certification by Quality Council of India, which validates all your safety protocols and SOPs for safe practice during the pandemic. We were the first eye hospital, almost the first. I was privileged to guide Arvind Eye Care System, Pondicherry, for this WASH. And they were the first actually, and we followed the WASH certificate, but that empowered our staff to continue working in the pandemic. And we were able to do because our system, our organization was already attuned to work with standard operating procedures. We didn't have to blink to start looking at newer SOPs and start working on it. In fact, you will find YouTube videos and staff training SOPs during COVID pandemic, which came out of our organization the first. That was a drop in the ocean to help people individual ophthalmologists struggling to survive in the pandemic. So that's the magic of SOP. In any inadvertent situation, this comes handy. Well, we have to understand, and I always believe that you can do something if you understand the why of it. Why do you really need SOPs? Human beings make mistakes because the systems, tasks, and processes they work in are poorly designed. Simple steps to improve processes. First, do not rely on memory, checklist. Simplify steps, process maps. Uniform care, documented processes. Learn from mistakes, incidents reporting culture. Recognize fatigue, have standard working hours, teamwork, importance, acknowledge the importance of the team from the doorman to the chairman. Reduce confusion. How do you do that? Documentation of communication, communication of documentation, and continuous education and training should become the new normal in your organization. So there is this webinar which I have taken, how to write an SOP. It's a 40 minutes webinar organized by CAHO, the Consortium of Accredited Healthcare Organizations. And I would recommend that you encourage your staff and you yourself as leaders of your organization, please see this. It's available on public domain on YouTube. How to write SOP, Dr. Zamindar, and you will enjoy and understand the nitty-gritty of how to write a standard operating procedure. So the first part of a SOP starts with our human resources, the most important resource of our organization. You know, when IKEA says, when they are looking for new employees, they say we are hiring Y-sayers, not yes-sayers. Yes. They don't want people who say yes. They want people to work with them who says why. They are hiring co-workers, not subordinates. So if there is a proper system in which you have a personal file for every employee, there is a privileging and a credentializing criteria, there is medical health checkups periodically, there is the antecedent checking which happens before you take them in, there is a kind of an appointment letter given to them, and everything done in a proper way, including their vaccinations if they are, vulnerable staff. So these things, this is the first step when a new staff or an employee joins your organization. Imagine that if all this is done and then the staff joins your organization, what will be the staff's impression for your organization? We are not talking about NABH, my friends, over here. We are talking about general attitude of the staff. They will feel that this is the organization where they have a future. They are going to grow. There is a system and they will get into the habit of following system. So much so that in our appointment letter, I have written categorically that our organization works with standard operating procedures and I accept to abide by them right from the appointment letter. Operation theater is one of the most important, dynamic, and a complicated area where the safety of patient requires great priority. So it's a no-brainer that operation theater processes, surgery, and anesthesia-related processes should be documented. Even if you're not talking about NABH, the Pollution Control Board actually mandates that you have a hospital infection control team, you have a monthly meeting of hospital infection control, and you note down the minutes of the meeting. So it's not all about NABH. If you want to practice, if you want to have your practice registered in your state, actually the pollution control boards, the rules of 2016 and amended in 2018 mandates that you have a hospital infection control committee and you have a hospital infection control manual. So we are just talking about practice and not about NABH. So documentation of HIC and OT will require surgery list, surgery-related medical records, registers, checklists for OT disinfection, and all kinds of checklists to see that there are no errors. Sterilization protocols. And who said that SOP should be dull and drab? We have all our sterilization protocols, all our OT protocols made by our OT staff into small videos. Either they are made and made into small audios or videos, and they are ready resource available to train the new staff when they join. Beautifully done. We need to learn to leverage technology and do this. Everybody has a smartphone. Why can't we do that? And so writing is there. Along with the writing, everything is done in a video or an audio. This gentleman, Atul Gawande, we should all be very proud of him. He's sitting in Boston, and he's the one who introduced the concept of surgical safety checklist. And surgical safety checklist is actually not a piece of paper. It is a drama played out in your operation theater before every single surgery, right? So you have a sign in, a timeout, and a sign out. And every single surgery, a piece of paper, that piece of paper is just the steps of the sign in, timeout, and sign out. But you need to do it, right? And you need to train. And it does really help you to reduce the errors of wrong site, wrong patient, wrong procedure, wrong intraocular lens, wrong intravitreal injection, any such thing. If you do the surgical safety checklist, not as a piece of paper mandated by NABH, but by something which is done every single patient, before every single patient, by the nurse in your operation theater. And my nurses love. I know there are some hospitals amongst you who have huge load of work, but believe you me, this takes a few seconds. While other things are happening, this can happen simultaneously. It does not take any time whatsoever. So besides the complying of the WHO surgical safety guidelines of sign in, time out, and sign out, there is something like safe anesthesia protocols. Like there is an American Society of Anesthesiologists grading of the patient. You need to have a document and an SOP that which patients can be taken in your operation theater. Like for example, in my operation theater, we say that we will take only patients with ASA grade 1 or 2. That means vulnerable patients, patients who have comorbidities, and comorbidities are under control. Do not have comorbidities, ASA grade 1, ASA grade 2, that they have comorbidities, but they are under control. So only these patients are allowed to be operated in Zamindar's Microsurgical Eye Center. So these are simple policies, a part of your SOP for anesthesia. So your readiness for any risk, systemic complications, are very, very less if there is abundance of clarity in this. Amsterdam preoperative anxiety checklist. That means you decide with a kind of a standardization that before the surgery, whether this patient is fit for a topical anesthesia or a peribulbar anesthesia. And the pre, per, and post anesthesia evaluation, again, to see that every time a patient comes into your operation theater, the safety of the patient is your responsibility, with or without anesthetist. Of course, if you're talking with the NABH guidelines, then it is always better to have a standby anesthetist in your operation theater. So the revised safety goals in an eye hospital: prevent mortality and morbidity due to systemic complications, prevent hospital-acquired infections, eliminate site-threatening complications, eliminate medical and diagnostic errors, ensure correct medication, ensure physical safety, besides the surgical safety checklist, which we already spoke about. OT scheduler is a beautiful piece of document which should be mandatory in every organization to be made at least 24 hours before the surgery. Person responsible, a signature to be handed over and to be put up in the operation theater. This small system can really, really iron out a lot of things which can go wrong in your operation theater. Accountability with key performance indicators for your theater managers, for your infection control team, for your surgeons and your anesthetist. And risk readiness. There should be a risk readiness for surgical site infection, our nightmare and endophthalmitis. So process maps and escalation maps in case of sterilization failure or positive cultures are very important. A sterilization failure process is something which all your OT staff should know about. And what to do if there is sterilization failure. First, how to identify that there is sterilization failure. A training on that. That at what does when is a load, a surgical load, a sterile load, unfit to be given to the operation theater, that your TSSU, your theater-based sterile surgical unit staff should be very much aware about. And they should be empowered to escalate immediately and stop the load. And this is something which is very, very important. If they are so scared of stopping that day's operation theater, then beware, you might end up into cluster endophthalmitis. So our theater-based sterile surgical unit technicians are the true warriors, and we need to give them the due respect and empower them to stop the load, even if there are 25 or 30 or 50 cases posted on that day. Medical emergency and fire risk readiness is also should be a part of your standard operating procedures. I will just give you now a few examples. I know I will run out of time, so quickly going through that. Grievance, we all, these are common examples. That patient grievance, staff grievance, everybody do sort of have their own ways of collecting grievance and acting upon them. But if you have an SOP, if you do not have an SOP, without SOP, the resolution is very sensitive, as the patient is already as upset. How to do it, who will do it, what is the method, what is the language used, what is the documentation required, what will you do, how will you do the root cause analysis and the preventive action so that the grievance doesn't repeat again. So if the grievance is not handled by a senior person in the most congenial manner, the issue can snowball into an unpleasant incident, right? So we all need to understand that when I talk about SOP, it's not about the NABH standards. It's about how to really improve the quality, your patient satisfaction, and the growth of your organization. Inventory management, all of us, I included my own self, have had faced stockouts at certain critical areas in my career, and I have faced consequences. So if you have a proper inventory management, a proper SOP for that, with reorder levels, economic ordering quantity, first in, first out, just in time inventory, many different ways in which you can have a proper inventory management. So this is something which is stuck outside my refrigerator, okay? And there is a reorder level decided for everything which is inside the refrigerator. There's a simple formula for the reorder level. If time permits, we will teach you about that. But this is so important that the staff knows that if that number reaches, immediately the order for that particular drug will go. Not this kind of inventory management. Appointments. Now, without SOP, what will happen? With SOP, what will happen? No clarity in patient flow, patient waiting time. See, patient waiting time is an important area where NABH is very particular, that your patient cannot wait for an indefinite amount of time in order to see you. And the vulnerable patients should definitely be taken quicker. There should be a prioritizing levels in your operation, in your OPD, to see that the vulnerable patients do not suffer consequences. For registration, without an SOP, there can be errors in fees collection, there can be errors in, confidentiality and personal data of the patient. So this is required, that there is an SOP at the registration. This is an example of our SOP at the registration, that there is a standard operating procedure, responsibility, who is responsible, and the supporting document. This is the simplest way in which you can enter. See, everything is written. The referral slip is entered. So if there is somebody who is referred, it becomes your duty to now send a feedback message to that person and say, thank you, this patient came to us and we have treated. This is not what NABH tells you to do. This is what you should do as your responsibility as a clinician, and as a matter of fact, to improve your kind of fraternity loyalty. This is the prioritizing kind of levels, what I was talking about, that this is a process map. A process map is also a part of your standard operating procedure. For example, this is registration and billing. This is how the flow should go. It's very clear. And there is this prioritizing level, right? So everywhere where there is patients of sudden loss of vision, eye injury, or waiting patient becomes visibly uncomfortable, suggesting a medical emergency, a foreign body in the eye, or there's an immediate post-operative patient, a patient with discharge where patient needs isolation. These are the prioritizing levels where the patient might have to bypass the optometrist and be directed straight away to the ophthalmologist. Investigations, again, without an SOP, there will be errors in finding, there'll be repeat resulting in waste of time and dissatisfaction among the patients. So there should be correct reading, there should be accurate calculations, there should be correct calibration, equipment maintenance, and there should be a critical equipment maintenance breakdown time. That if a critical equipment goes down, what is your allowed downtime and what is your TAT, your turnaround time for that particular equipment. All these things will eventually ensure that your organization does not suffer losses and your patient does not have to face the consequences of that. Consultant communication, very, very important, right? There is this wonderful book known as The Blink by Malcolm Gladwell, and which says that within the first 3 minutes, when the patient is inside your OPD room, and a new patient will decide about what kind of a doctor you are. So the communication, and some more communication. I would like to share with all of you that our team at Zamindar's Eye Center, along with a distinguished panel of guest speakers from across India, has done a communication workshop at the last AIOS. And if you do get a recording, if I get a recording, I will share. If you do get a recording, share with me. But that was a wonderful course to make everybody understand the importance of communication at all levels in our hospitals. And we have a documentation of communication and communication of documentation. So a consultant communication without the SOP, the advice is not followed correctly, the expectations of treatment are not correct, and there will be a decreasing patient satisfaction. Counseling, again, without SOP, the patient may be confused on treatment plans, rates and tariffs, pre-operative care, post-operative care, and patient may be too scared to undergo a surgery. So your counselor becomes your second most important person, and it is important that he or she works with a standard operating procedure. Insurance. A lot of people in especially in a city like Bangalore, we do a lot of cashless transaction, and without an SOP, if there is a difference amount between the surgery amount and the insurance authorized amount, the patient places the blame on the hospital if there is no particular SOP and communication with the patient. In fact, something interesting what I would like over here is that we have a statement of acceptance and understanding of the cost of surgery, which is signed by every single patient. It is a mandation now by the ECO standards, but even without that, a statement of acceptance and understanding of the cost of surgery. So they understand. Sometimes some foreigner patient, they don't even understand that this cost is only for one eye, not for two eyes. So we have, this is for one eye, this is the intraocular lens, this is what the lens will give you, and this is the exact amount and a signature from the patient. And this is the amount which your insurance company will give you. So these are simple things in documentation and SOP, which will really help you function well as a unit. So I would like to thank my team. I can only be as good as my team. So without their support and a continuous encouragement, I think we would have not started our third center, Zamindar's Eye Center, which is a COVID-safe facility in Bangalore. And like Dr. Sudipta and Dr. Sanchita mentioned, that we run an Eye for Quality, a share, learn and teach, a knowledge sharing platform at our center. All of you are welcome to be a part of that. We do it online now in the pandemic. And friends, just like Rumi said, as you start to walk out on the way appears. Do not be afraid. Take the plunge. Go for NABH. Not for any other reasons, but for improving the quality and the staff morale. Thank you so much. Thanks a lot.
That was excellent, madam. That was great. Whenever you are speaking, it is like keep on hearing you. It's splendid to hear you because it's always learning. So thank you very much for that very informative SOP. I am sure we have lots and lots of questions and lots to learn from you. But going on with it, we'll go to the next speaker of the evening and we'll come back to you with the questions later on. So please stay with us, madam. Our next speaker will be Dr. Shondip Mitru, sir. All of us know him as a prolific surgeon, as
Sudipta, Sudipta, sorry to interrupt you. I think in the group we discussed that Anuradha will go before.
Okay, no issues.
So
Anuradha, who is attached with Shrut Eye Hospital and is very well known as a pediatric ophthalmologist, will be speaking now on NABH for big eye centers. So over to you, Anuradha. You can share your slides.
Thank you. Am I audible?
Yes.
Yes, you're very well audible.
Thank you, Shudipta Di. Thank you, Shudavata Da, for inviting me in this seminar. This is a wonderful seminar and very meticulously made. I would be discussing some constraints that we come across when we are in a big hospital. Okay, so coming to the question, how big is a big hospital? Usually a 50-bedded hospital is considered to be a CHCO, but in the eye care settings, it is not applicable. So a daycare center with a footfall more than 200 would be considered as big. So constraints. The problem with a big hospital is the hospital is already running for a long time and the system is in place. Often it is not complete and maybe it requires an updation. The stakeholders and the doctors are often overburdened, and the documentation and the record maintenance is not always the first thing that comes to mind. Codes like blue and red, they are always maintained, but they are sometimes they seem superfluous and unnecessary until a disaster or a crisis strikes. And training seems unnecessary waste of time for the doctors, maybe because they have already so many patients to look after. So other part is the biomedical and the safety, because these are the supportive departments, and many a times the documents of these instruments and fans, other non-medical equipment are lost and not traceable because of the long duration of the hospital. Many a times AMC and other maintenance is often lacking, and it becomes difficult to keep track of hundreds of machines. So my hospital has done a wonderful job here. We have got a QR code for each machine, and by using that QR code, we can trace its AMC and all other documents. So that was a wonderful work done by Dr. Arindam Dev, and I would really appreciate it. The other thing is the human resource. Again, this is a very unorganized, usually remains unorganized and neglected, and usually remains as a single person show. Only a manager takes care of everything. So once we start building up our hospital for NABH, we get documentations of the interviews of the employees during recruitment, during exit, and during their yearly assessment of satisfaction level. The morale of the staff also increases once we start implementing these processes, not only for NABH, but also for the hospital. It plays a wonderful role. And the training is the most important part of HR. So you have to train the patient, train your staff in every possible way in order to get a good functioning. So the SOPs that are made are to be trained to the, so that it reaches the lowermost level of the staff and it is implemented meticulously. HIC and patient safety. Often this is a very important part of the hospital functioning, and the stakeholders are usually very sincere in its function. But many a times what is lacking is the designation and the required training. Many a times you don't have a certified nurse for infection control, which is a must for NABH, and this has to be done if you want your hospital to be NABH accredited. CSSD practices have to be very well documented. It has to be checked daily. The temperature and the sterilization biomedical tags have to be documented in the register and has to be checked periodically. And those registers have to be well maintained so that at the time of NABH assessment, they are available whenever they want to see it. Pharmacy and drug management, again, this is a well recorded and well maintained department. But many a times what happens is that you don't have a very good records of the anesthetic drugs which are being used, and they are checked meticulously by the NABH. So once you are deciding that you want to go for NABH, you have to maintain the records of the anesthetic drugs, how you procured them, how they are used, how much is used for every patient has to be recorded while the anesthesia has been given, and how they are discarded. So all the three parts of the anesthetic drugs have to be maintained. So once you are decided that we have to get NABH, it has to be a commitment from the highest level. You have to form the required committees, and you have to try to take as many doctors and the staff on the board as possible. You have to develop a quality team and a department with a full-time quality manager and a consultant in charge. They will take care of all the SOPs and the documentations and maintenance of forms, instructions, and checklists. You have to have that relevant NABH standard copy, as Dr. Shutanda Shore has already shown us. And you have to get at least 1 or 2 persons in the quality trained for this course. The steps, I think they have been very meticulously explained by Dr. Shutanda Shore. I would just go through them. So once you have decided you want to get accredited, you have to purchase the standards and you have to arrange for the training. The preparation of the quality manual is a very important part because it decides how your hospital is going to function, what are your mission and vision, and how your hospital is going to show itself to the world. So apply in the NABH portal, conduct an internal audit. NABH will schedule a pre-assessment to assess the scope. Usually it is a huge list of non-compliances. Many of them may be infrastructural, many of them will be documentation related, and these have to be closed very meticulously. Usually it takes a huge time in order to get the pre-assessment and non-compliances covered. Then you have to close the observation and schedule a main assessment. Once the main assessment is done, so the number of non-compliances reduces. It may come down to maybe 40 or 50. And you have to close these observations within maximum 2 cycles. Then there will be a NABH meeting for recommending the accreditation, and the accreditation would be given. Statutory and legal requirements. These are always, these have to be uploaded in the portal at the time of application. These are always available in the hospital, but what we need to remember is that at least it should be valid for next 2 years, so that you don't need to renew them during the accreditation cycle. And it is a good practice to prepare a tracker sheet and share it with the NABH. Document pyramid, we had a extensive discussion on why you should have a SOP. So you need to first develop your quality manual, and it has to be according to your own hospital, according to your vision and mission. Then you develop the SOPs. After the SOP, you need to break it down to forms and work instructions, because the SOP cannot be remembered by each and every staff. You need to give the relevant staff the relevant work instructions so that they can be able to use them in their day-to-day practice. The important part is monitoring that whether these are being implemented. So preparing the quality manual, as I told you, it has to be according to your hospital, what you commit to do. That should be the most important thing in this quality manual. And many a times you would find many copies, many different types, but you have to change it according to your organization, and you should be committed to follow it word to word. Writing an SOP, it has to be as elaborate as possible, as meticulous as possible. Every step has to be covered in a SOP. A good SOP should be such that a novice can perform the job very smoothly by just reading the SOP. And it has to be what you actually practice in the hospital. If you don't practice it, even if you write many things in the SOP, it is going to be bound. It is bound that the NABH will find errors with it. So whatever you practice in your hospital, it has to be written in the SOP. And orphan SOP is one which is not linked to the NABH protocol. So we have a number of numbers in the NABH, and you have to link it with that, so that whenever you want to get or procure that SOP, it can be easily found out. What we have done is we have a HMS in which you can procure each and every SOP you want. So it should be available, readily available, and it should not be like you are, when they want, the NABH wants a particular pharmacy SOP or OT SOP, and you are running about and trying to find out where it is. So that is very important. You write an SOP and it should be in a place where it is easily availed. Forms and instructions, the consent forms are the most important things that a hospital has to have, and these consent forms have to be meticulously filled, so they have to be implemented in everyday practice. And definitely there must be a monitoring system in which the daily checklist and monitoring of the consent forms and the instruction forms which are being filled up is regularly checked. And this is completely a task of the quality team and the quality department, and this has to be done very meticulously. Thank you. I think I have just gone through few important points, and there are lots of points in NABH. So thank you, Shudipta.
Yeah, thank you, Anuradha. I think Dr. Zamindar will have to join another webinar. So is there any questions to Dr. Zamindar? From the other speakers or panelists? If there's no question, I have a question, Dr. Zamindar. So I got my entry-level accreditation with my own SOP writing and everything. Now, if I go for full accreditation, so is there any difference of SOPs, or the same SOP will continue with any other addition I have to do?
So, Dr. Sharaf, thank you so much for the question. The SOP will remain the same, but there are some standards which are added.
Yes, that's what I wanted to know.
Added. And there are newer things like financial aspects of counseling. That is a new SOP over there. Then SOP about the credentializing, and SOP about there are certain things which will be added. Clinical audit is a very important part of the main standards, the eco standards. So you'll have to do clinical audits and show that and add that to that. And so obviously we have very limited standards. Very core standards of safety and quality are there in entry level, but the full standards is the eco standards, is a full NABH, and which will have many more standards. So you'll have to just keep adding. That is if you're going for eco standards. Even otherwise, every year, all your standard operating procedures have to be revised. Your SOP manual has to be revised annually. So you'll have to check and see if there is some old method you're doing or something new you've added. You will have to now revise them and say revised edition. And every SOP manual for that particular thing will have a new kind of a date and a number, a revised edition number. There's one more thing which I wanted to share with everybody, is that even if you're not looking at NABH, there are some important forms which you should have in your organization. One of them is a code blue form, because a medical emergency and a code blue situation can arise in any of our organizations. And we should be able to call for a code blue. We should be able to give basic life support, and we should be able to document the minutes of the meeting of the code blue. If you have done that, then you are safe in a court of law, that you have done your best as a doctor to avert death. But if you are not able, even if you have done it and if you have not documented in a form of code blue, you might be in trouble. So these are simple examples of the importance of documentation in your hospital.
Hello.
Yes.
Hello. Dr. Zamindar.
Yes, please tell me.
I'm Dr. Mukherjee, Sushant Mukherjee. My question is, hello. My question is that regarding counseling, is it required that documentation of the counseling is necessary? Because what I have done the counseling, there is no record what I have done or what I have regarding counseling and what I want to explain to the patient. It is not documentation of the counseling is necessary, or
Financial aspect of the counseling is a separate objective element in eco standards. If you have to prove that you're doing it, you will have to. So that's what I told, no, that we just have a simple kind of a thing in our OT records, that a statement of acceptance and understanding of the financial aspects of the surgery. And then written that I have chosen this intraocular lens. I understand this is what it is I have to pay. This is this, and a signature. This is much more than NABH. It's going to reduce a lot of your headaches, Dr. Mukherjee. So please do it.
I think Dr. Zamindar, Dr. Mukherjee is asking about other points of counseling also.
Not
right?
required. No, that's not required. But yes,
regarding prognosis of the case or explaining.
Prognosis will come in your consent, doctor.
No, sometimes it is hard that
it is an OPD case only.
Nowadays, Dr. Saurabh, nowadays it is hard about that documentation of the counseling is video recording is also needed, not only for NABH but court of law video recording of the counseling. You have done the counseling, there is no proof or record. Yes. Apart from NABH, sometimes in other
in the court of law, you wanted to know, yes.
Yeah, documentation of counseling, because I have done the counseling, patient is signing, and it is regarding the other consent forms, counseling of the documentation of the counseling. What I mean to say that I have counseled these things, and patient is agreeing these things, and is this documentation that I have been counseled. Patient can deny that I have not been counseled.
Yeah, Dr. Mukherjee, I think what you're trying to ask is that the consent taking process, we just take a document and a signature, and there is a signature of the surgeon, the time and date is important, the signature of the patient, and one more witness, right? These three things we already are doing. All of us are already doing, and in that consent, a lot of things are there. Complications, side effects, alternative procedures, everything is there as a part of the consent according to the NABH compliant consent. In some high-risk cases where you want to safeguard, it's always a good idea to take a video of that, right? It is a good idea. I'm not doing it, but if yours is a hospital where you do a lot of high-risk cases and you want to safeguard yourself, please do one more step and video record. There's no harm to that.
Thank you.
Can we move on to the next speaker?
Thank you.
Thank you, Dr.
I'll have to leave, but I enjoyed my time here, and thanks to everybody.
Thank you,
Dr. Zamindar, for your time for Ophthalmological Society of West Bengal. Thank you very, very much.
Thank you. Call upon Dr. Sandeep Mitra.
I'll share my screen.
Yes, Sandeep. Go ahead. Sandeep is very well-known ophthalmologist in West Bengal, and he's having his individual setup at Kurba Eye Care, and he got his accreditation a few months back. So I think Sandeep will be able to tell us about how he has got this NABH accreditation in a small single standalone setup. Sandeep, you can go ahead.
Am I audible?
Yes, absolutely.
Good evening. Okay. I think my slide is giving little problem. So good evening. Thank you, Dr. Sugato, and thank you, WSWB, for inviting me in this webinar. And am I audible? Hello?
Yes, sir. Yes, very much. Very much.
Yes,
please
go
go on. Please.
Right, because I think my laptop is giving little problem. So I just asking
Just
you.
make it full screen. Just make it full screen, sir.
Yeah, then I am losing the slides actually.
Okay, no, no
Okay,
issues.
go ahead.
Go on, go on, go on. Go ahead. Go ahead.
I also take this opportunity to thank Dr. Saurabh Sannal, who helped me in getting my accreditation. He actually guided me. He gave us a lot of tutorial sort of thing and helped us immensely. So my talk is NABH for standalone practice. And what actually is meant is NABH for small practices and small clinics. And so long we were listening to all the procedures that is needed for NABH accreditation, why it is needed, how SOP should be written, and how accreditation is done for big hospitals. But my talk is to give confidence to standalone practitioners, to small clinics, that it can be done. It is not that difficult to get NABH accreditation for small clinics. So what does it mean for small clinics? Accreditation by NABH is a proof that the hospital provides quality healthcare. It's comparable with the big corporate hospitals with fancy interiors, a testimony that the hospital wishes to improve the patient's experience positively, and also a mark of recognition. So our is a small clinic, and I'll give an idea how small it is. We have an OPD with some testing facility. We have an OT and a 5-bedded daycare center, also an optical unit with a dispensing facility for contact lenses and LVA. So frankly speaking, it's a small one, but NABH accreditation is possible even for the small clinics, because they don't look for the quantity, they look for the quality. Now, why it is useful for small clinics? It teaches us to define and display services. A lot of things we are doing, but we do not define it and we do not display it, and the patients may not be aware. It is a well-defined registration, admission, and record-keeping system is introduced automatically when we go for NABH accreditation system. Documentation of discharge, consent, etc. has become very clear and very precise. Proper organization and storage of medicines and consumables, that also is important, and NABH teaches us how to properly organize the storage system and document them. Proper method of sterilization and infection control, and also biomedical waste management, which comes automatically when we apply for the NABH accreditation. Now, difficulties faced by small clinics, and are they really big? The first difficulty is a space crunch. First we have to see whether we have the space to, do the alterations and renovations, whether we can, which are needed to comply with the guidelines of the NABH. And in most of the cases, these alterations and renovations are not that big. They can be done even in the clinic is small, and space is not that difficulty, because when you are already having this kind of clinic, we have spaces for different areas for different activities. Second thing is the staff. The strength and quality of the staff is important so far as NABH application is concerned, and other statutory compliances. But since in West Bengal we have a strict Clinical Establishment Act, most of the clinics already have those statutory compliances and requisite staffs, with the quality and the certification needed for that job. Record keeping is another area, but nowadays, with the help of all these softwares, record keeping is not that difficult, and it does not require any space either. The installation of firefighting system, that is a kind of fear we already have before applying to NABH accreditation, that whether what kind of installation, what kind of arrangement are to be made. But at the end, it was seen that only a few smoke detectors, a few fire alarms, and a few firefighting arrangements are needed. And especially this is I'm talking about for entry level, accreditation certification. So the changes made for this entry level small healthcare units actually helped these small clinics to get this kind of certification. Now, another thing before we started the committees, there are multiple committees that are needed to apply for this, like quality improvement, infection control, pharmacotherapeutic, medical audit, safety, grievance redressal, and disaster preparedness and ethics committees. These are the committees needed. But actually, when we applied, we learned that for small clinics, with limited number of staffs, the multidisciplinary committee, one multidisciplinary committee is all that is needed, which which is responsible, which will remain responsible for all the jobs for all these committees. So we did not have to make so many committees and appoint so many staff. Another thing, before we started, it was in our mind whether modular OT is needed, whether laminar airflow is needed, whether centralized AC is needed. But all those things were not needed, especially I'm talking about this for entry level, quality certification. So in my opinion, the biggest, hurdle is the mental block, and the mental block we have to overcome. We have to, be confident, and we have to be, first we have to accept that yes, this NABH accreditation is needed and we can do this. And this mental block also comes from the fact that there is lack of information. Even a few years back, we really did not have any clear idea what are the things needed for NABH accreditation. So once you get the full information, the mental block, goes, and we start doing. And when you start doing, little changes can be done, and whatever is needed can be added on. And finally, you can get the accreditation from the NABH thing. So why we did that? In my opinion, we did that because it gives, it's a kind of self-assessment. You put yourself in a test whether the quality, the service and the quality you are providing is at par with the NABH or the international standard. And it also, there was an, I don't know whether it's a rumor or the, news that approval for cashless facility will be given in future only to the centers which has NABH accreditations. I don't know how far it is true, but that there was a a rumor going on. So we actually did that. So that we already have a cashless facility. To continue that cashless facility, we thought that we better go for NABH accreditation. It also gives you some kind of recognition that yes, this center has NABH accreditation, and also gives you confidence, as Dr. Zamindar also said, your self-confidence and confidence to your staffs that yes, your center has NABH accreditation. So thank you so much. And this is the small information that I wanted to share with you, that even being a small healthcare unit, we can easily apply and get NABH accreditation for the entry level NABH accreditation. Thank you so much.
Thank you, Shunita. That was very informative and excellent. And it's very encouraging for small centers who actually, the mental block that you say is having the mental block, that having a lot of work to be done in documentation, learning process. So that is where it is very, very important, especially for the people who are actually having small centers, small staff, small facilities. So thank you so much for sharing your experience. I'm sure this will be helpful. So without wasting much time, we will go on to our next speaker. I think Shorabda, will you be introducing? Or should I do
No,
that?
you introduce Anjun.
Okay, just a second. Just a second, please. Having problem in sharing the slide actually.
Just verbally introducing. No, become slide.
Just a second. Is my slide visible?
Yes.
Oh no.
Yes, visible.
Yeah, yes, yeah. So next speaker will be Dr. Anjun Mukherjee. And Dr. Anjun Mukherjee is currently a consultant microbiologist with Apollo Multispeciality Hospital, Kolkata. He's a MD from AIMS in microbiology. He's an ex-senior resident, Department of Microbiology, AIMS. A decade of postgraduate experience he has gathered across various government and private organizations in Delhi and Kolkata. Honorary Secretary of Hospital Infection Society India, Kolkata chapter. He is a NABH assessor of entry-level hospitals. He has research experience and publications in peer-reviewed national and international journals, and is a certified infection control practitioner. Today, he is going to speak to us on a topic NABH from assessor's point of view. So welcome, Dr. Anjun Mukherjee, sir, and over to you. You can share your slides now. Sir, we do not hear you.
Yeah, now can you hear me?
No, sir, it's very faint. Just speak a bit louder. Or...
Yeah.
Yes, sir.
It's
That's
right?
better.
Yeah.
Yes, it's perfect. It's perfect. Perfect.
Okay, thank you. Thank you very much for your kind introduction. Before I begin, a statutory disclaimer on behalf of NABH. The opinions expressed in the talk are that of mine, individual. It does not necessarily reflect the official position of NABH. And this is not a consultancy service for any healthcare organization, just a candid academic discussion in a professional group. And for the purpose of brevity, he or him in this presentation is used as gender neutral. So first things first. Okay, the general profile of an assessor. No assessor is in the fixed payroll of NABH. They are paid per assessment days. So basically what I mean to say, they are individual, free, independent persons, and by and large, a decade of postgraduate experience is required to qualify as an assessor. Most assessors are actually self-employed. They have their own organization. Some of them are semi-retired. And an NABH assessor can be a medical doctor, a senior nursing professional, or even a healthcare administrator can be an NABH assessor. Now, by this time, those of you who have gone for NABH accreditation know that there are various types of assessment. One is the virtual, which has now become the norm, unfortunately, post-COVID. This is usually over Microsoft Teams software. We usually have a hybrid model nowadays because with the subsidence of second wave of COVID, this is most tricky because one assessor is on site and he's coordinating with the other who is sitting somewhere else. And you would all agree with me, best mode would be on site. That is, the assessor is there on the ground, assessing the hospital, standing on the very site.
Shugato, kindly mute yourself.
Sorry, I don't know.
I'm sorry, Anjun sir, please go on.
No, it's fine.
Very sorry.
Do I continue? No problem. It's fine. Okay. So next is, I think we have had some discussion, entry-level certification versus full accreditation. There is a difference between NABH entry-level, which we otherwise called as NABH accredited certification, and versus full accreditation. Hope portal is used nowadays for entry-level certification programs. The only difference between accreditation and certification is that accreditation programs are traceable through ISQA, while certification programs are not traceable. Now, the role of an assessor. An assessor is supposed to act as the eyes and ears of NABH during assessment. He is the representative of NABH during audits and hence is bound by NABH Code of Conduct. He is expected to check for conformity to a well-defined set of standards and objective elements which are given in the NABH standard book. He is supposed to document his observations on the day of assessment and share it with the healthcare organization. The healthcare organization is supposed to answer the raised queries to the satisfaction of the assessor. And after 2 cycles, the assessor submits a report to the accreditation committee for final meetings. Now, the last 2 points have been highlighted in red. Please note, even if you do not remember anything else, please note this. An assessor can neither grant nor cancel your accreditation. He can only share his findings. He cannot even recommend giving or not giving accreditation when he is submitting his final report. He can just give whatever he saw. Now, assessor is supposed to do what we technically would call handholding. He is supposed to discuss with the healthcare organization clearly on the observations raised and how to close it. He cannot be ambiguous in this issue. Like he cannot say that I see that your hospital has this problem, but I don't know how you will close it. So this is his duty to clearly indicate how to close it. He is not supposed to provide any expert advice or consultancy service to the hospital. He is not supposed to start teaching the hospital on the various aspects of NABH or maybe something in which he is a specialist in. He is to avoid comparisons with his own hospital or other places he may have visited. He is supposed to remain flexible, like many of my other speakers have pointed out. There are small hospitals, there are entry-level hospitals who have their own constraints, who may not be as big as some other hospitals. So we have to take all of them on board for processing. He is not supposed to comment on issues outside the purview of assessment. For example, the decor of the hospital or its vastu compliance. So in short, the assessor will audit. He will not teach or do inspection. Now, role of healthcare before the assessment. The healthcare organization is supposed to get in touch with the assessor well in advance, clarify with him the requirement of documents, discuss his travel plans and accommodation, especially for on-site, requirement of technical support, especially for virtual. This becomes a very critical issue. So you should consider having a mock or virtual session a day before in order to test the net speed and that of equipment. And please maintain what you call SPOC or single point of contact as far as the hospital is concerned. It becomes very difficult for the assessor if 3 people from the same hospital calls up for 3 different reasons. For example, 1 person calls up for assessment, 1 for accommodation, 1 for transport. So that becomes a bit of a problem. So please try to maintain a single point of contact during the assessment. Now, this is another very important point. Please be honest with the assessor. Do not try to trick him. Do not try to outsmart him. Whatever your hospital is, whatever work you are doing, please share with him honestly. He's there to help you. He's not there to criticize or judge you. Be polite with the assessor. That, of course, everyone would. No need to cancel all your OPDs or OTs for the assessment. Rather, it is better if your hospital is working full strength. You can spend an hour or 2 with the hospital from your schedule, with the assessor from your schedule, but you do not need to be with him for the whole day. Allot 1 responsible staff member to each assessor to show them around. That's all. Most assessors would have a prepared schedule, so please try to stick to it. Do not request him for a change of schedule just because you have some problem in that area. Try to arrange the lunch and tea within the hospital. If you want to take them out to a nearby 5-star hotel, you are basically wasting your time and that of the assessor, which may cause problems during the assessment, especially if it's a single day event. Like the hospital may have the assessor may have to leave by evening, so that becomes very difficult. Club your management review meeting with the bonding team. So these are small issues that will save time. Last but not the least, your net speed and the camera should be perfect. Now, many a times, those of you who have had assessments in your hospital, you may have seen that an observer is often allotted to an assessment in order to familiarize him with the process of assessment. He is a future assessor, and The healthcare organization is not responsible for its traveler accommodation. Observer has no authority to raise any observations as far as the hospital is concerned, but many a times the assessor do ask him for his opinion if he's a domain expert. After the assessment, the assessor is supposed to mention all observations in the closing meeting. The healthcare organization must have a very clear idea on the closure and still stick to the same. This is very important. At the closing meeting, please discuss frankly with the assessor that, sir, this is the point you have raised and this is what I plan to do. Please suggest, opine, and we will do accordingly. Closing is usually done in the afternoon. Make sure to have an office facility ready, because the assessor, if it's an on-site assessment, the assessor will need a printer, scanner, a lot of things to mail to NABH. And this is a bit of a hectic thing to do with time constraints. Please help the assessor by having a dynamic IT guy around. Please do not try to personally contact the assessor after the assessment is over. The moment the assessment is done, the assessor leaves your premises. He is on his own. You are on your own. In case you need to contact the assessor, please do it through the NABH. They will help you out. Once you submit the closure, the assessor is automatically intimated. So you need not call the assessor personally and tell him that, sir, we have sent the closures. Please do the needful. You do not need to do that. The assessor is automatically intimated through an automated mailing system. Dealing with observations. This is very important. Please do not take these observations personally. They are not a reflection on the quality of work you are doing in your hospital. So please don't worry. And the number of observations do not count. My hospital got 5, your hospital got 10, doesn't make your hospital inferior to my hospital in any way. So what counts is whether all the observations are closable. Now, non-conformities or observations on infrastructures are what is difficult to close, as Dr. Vitro has pointed out in his last presentation. Within a short frame of time, you may have space constraint, you may be a small organization. So avoid it. So if you, in case you have infrastructure issues, try to close it before you apply for the final NABH assessment. So that will save both your time and that of the NABH time. Please avoid these common pitfalls. Do not get into a prolonged discussion with the assessor on a particular observation. Please don't try to close any observation on site. Like many a times what we have is that somebody comes with a, if I point out that our roster is missing, somebody half an hour later points out, sir, we have this roster prepared, we did not show it. So you don't need to do that. You can take your time, you can do it and make it a practice and then send it. Remember, it is the assessor's job to give NCs, just as it is your job to defend your healthcare organization. So please let the assessor do his job and don't take observations personally. Please stick to your commitments while sending the closure. Don't send a closure which you have not discussed with the assessor during your closing meeting on the day of the assessment. Thank you very much. And thanks WSWB and all its members for giving me a chance to discuss this very important issue with you. Thank you.
Thank you, Anjun, for your excellent presentation on assessor's point of view.
Hello.
I think I am audible to all of you.
Yes.
Please unshare your screen, Anjun.
Yes.
So now I would like to ask the panelist, Dr. Sarkar is there? Dr. Devi Sarkar? Dr. Arup Bosch is there?
There, yeah, yes, I'm there.
Arup, you're there?
Yes, I'm there.
So I would like to ask you, you have also gone through this process.
Yes.
So what is your suggestions? Who are all waiting for their centers to get accredited?
Now, basically, I'd like to share in a very nutshell about my experience. And during my about 25 years of practice, I used to think that whatever I had been doing is all right. Patients are happy. I'm satisfied. And when in 2017, had been to Dr. Zamindar's place for an orientation. And there I realized that what the things that I had been doing is okay for an individual if you are taking care of everything yourself. If your machinery or if your center has to be self-sufficient, you'll have to have a very organized sort of a system, and NABH can help you in getting that. So after having done NABH in 2019, I realized that things have become so easy. Easy in a sense that even if I'm not there, my staff know if there is a needle prick injury, what to do. If there is something wrong, if a medicine error has occurred, what to do. If there is a fire, what to do. They know everything, and everything is under control. And even if you are not there at your center, things are running fine. So I tell everybody that even small hospitals, standalone places, individual practitioners, that you should go for NABH. It's very easy to get. It's not at all difficult. Only thing initially, you'll have to get your things organized, do a bit of documentation, but it ultimately helps in the process of making your things much better and give a much better quality of service to your patients. And it's good for the staff also.
Your organization is entry-level accredited?
It's entry-level, and we have renewed only last month. So it's the time now.
Now you are renewed for another year?
Another 2 years.
Another 2 years. Then you go for the final.
And then I'll go for the final. Now I think there is this thing as circular has come that you can continue with entry-level.
Okay. And other panelists, may I call Dr. Ashit Chakraborty, sir? You are there? Dr. Ashit Chakraborty? Dr. D.B. Sardar from Kuch Bihar? I think they have not joined us. Oyan, you are there?
Oyan is driving, so he called me, but Dr. Divi Sharkar is here.
I think he's not unable to communicate to him.
Okay, we have some experienced people like Dr. Arup Chakraborty is there, Dr. Shubhra Shil is there. We can involve them in the discussion because it's an open meeting, so we can involve them in discussion as well.
Okay, you can ask them questions. Sushanta, you want to say something?
Yeah. Basically, I want to specify that NABH, everybody has discussed the same. I briefly point out the thing that in the beginning, 2017, when I started the training, to Dr. Zamindar Center. After that, it was that time it was not clear to everybody. Nowadays, it is little bit clear to most of the persons. But two to three things I want to specify what Dr. Arup Ghosh has pointed out, that it is my conclusion that everybody should go for NABH accreditation for two things. It is not like that NABH is something they are want to make some rules like clinical establishment, you have to do like things. They want to make what you, Saurabh, you have pointed out your lecture that NABH is making us in the right pathway. Whatever everybody we know, NABH want to make us right pathway. First and foremost thing, you get your acceptance. You will two things. One is through documentation. Nowadays, it is very easy through softwares. So many softwares are available. Once you go to the softwares, documentation is okay, and go to the HIC, Hospital Infection Control, OT, and Hospital Infection Control. Rest of the things comes automatically. And you will improve everything. And and third most things, Dr. Samina has pointed out, I have learned from her. What he points every time. From the very beginning, 217 from the training, I have pointed to one point. She told, and today also she told same thing, that don't appoint a consultant team in the beginning.
Yes.
Don't appoint a consultant in the evening. You will not learn anything. Your staffs will, if you won't learn anything, your staffs will also not learn anything. You will get the certificate, but the process, what NABH wants, I want to repeat, first you try yourself, do your SOP, go on, consult with the seniors like you or Udda who has already done, consult with them, visit their centers, do self-assessment, internal assessment. Then if you stuck to anywhere, you can consult with any consultant team. But from the very beginning, don't I want NABH and give a consultant team. They will come, they will do some copy-paste things, they will cover your assessment and you will get the NABH certificate. But the proper what NABH wants to make ourselves in the right track, that will be not fulfilled. It is my suggestion to everybody which is going to NABH. Big hospitals, they have so many teams, they have other things, but individual, what Sandipta is telling, my centers is also same like this. But everybody can do that way, and you will be in the right track and you will be in the right way. It is not a things, it is something big, something what I will tell in a page, but go for the proper way, go your SOP yourself and consult with the other consultants like you or Udda, and visit their centers and try yourself. Then you will get the NABH and proper process what NABH wants to ourselves.
Okay. Anybody wants to make other points? Anybody? Rotishda, you want? Rotishda is there? I think we have.
I am here, but I am traveling.
Okay, okay. Rotishda.
By comment.
Okay, you must.
Yes.
Only what I have learned today, 2-3 points. Those who have not applied for NABH, or those who has been accredited, or those who are in the entry level, it is a continuous process. Number one. Number two, NABH mostly concerns with the safety. And probably the best understanding and the best practice of the NABH will be documentation. So some of my colleagues asked me, probably it's giving little bit more expensive because its infrastructure is not that important one. But the other part, these processes and the SOPs is really an important one. And some of the infrastructure changes may involve a little bit more money. But the experience is this: if you invest this money, this is going to come back to you in a return will be more. So don't hesitate about this. So this is the learning. Probably it is not an I don't know. Sushanto has raised the point. Probably the cashless for this, it will be mandatory to have the NABH. These are probably not the fact, but of course, if you have an NABH, you can charge little bit more, even like CGHS, WBHS, and some other agencies are there. So with these few points, I think I must congratulate, the scientific team, the speakers, the moderators, everything was excellent. It was a good learning for me. That's much I can say. Thank you.
Thank you. I think we can close it now. So,
Rupak is there. Rupak Kanti Bishwas. Rupak, are you your center? Are you planning for NABH or is the process started? I just wanted to check if there is any center who are starting, how they are starting. Rupak. No. So in that case, yeah, we can close the meeting, and as I can thank all the speakers, especially our guest speaker, Dr. Anjun Mukherjee and Dr. Zamindar, for taking their time out for Ophthalmological Society of West Bengal, and all the panelists for that time, and Saurabh and Sudipta for excellently moderating the meeting. Thank you so much. So we'll meet again very soon. Thank you.
Thank you.
Thank you.
Saurabh, if you can stop recording.
Thank you, everybody.
Thanks.
রেকর্ডিংটা তো এখানে দেখাচ্ছে না সুদীপ্ত, সুগত।
নিচে দেখো রেকর্ডিং এর ওই সুইচটা, ঠিক আছে, মিটিং ক্লোজ করলেই রেকর্ডিং এই হয়ে যাবে। ক্লাউডে করেছো তো?
হ্যাঁ হ্যাঁ।
তুমি দেখো ওপরে রেকর্ডিং, ওপরে বা নিচে একদম শেয়ার স্ক্রিনের পাশে রেকর্ডিং এর যে বাটনটা আছে।
দেখাচ্ছে না এখন, সেটাই দিচ্ছি। দেখাচ্ছে, তখন তো দেখাচ্ছিল।
ওপরে দেখো তো, ওপরে দেখো, ওপরের লেফট কর্নারে
দেখাচ্ছে না।
আমার এখানে দেখাচ্ছে রেকর্ডিং।
স্টপ করে দাও।
না, কিন্তু আমি স্টপ করতে পারবো না, তুমি হোস্ট তো।
ও, এখানে কিন্তু দেখাচ্ছে না।
আচ্ছা ঠিক আছে, ঠিক আছে।
শেয়ার স্ক্রিনের পাশে আর রেকর্ডিংটা দেখাচ্ছে না। বন্ধ হয়ে, এই যে এখানে আছে রেকর্ডিং। ইয়েস, বন্ধ করে দিই।
হ্যাঁ।
এখানে রেকর্ডিং এ ক্লিক করলে লাল হয়ে আছে, কিন্তু এটা দেখাচ্ছে, বন্ধ করাটা যাচ্ছে না তো।
আচ্ছা দাঁড়াও দেখছি।
দেখাচ্ছে না।
ঠিক আছে, ডোন্ট ওয়ারি, আমি 1 সেকেন্ডে যদি নিজেকে হোস্ট করে নিই, করে রেকর্ডিং যদি স্টপ করতে পারি। হ্যাঁ,
করেছো স্টপ?
হ্যাঁ।